Good afternoon, everyone. Once again, it's a pleasure to see all of you. My name is Steve Keller. I am the program developer and national speaker for Substance. Thank you for joining us in today's webinar titled The Overdose Crisis, as we are currently focusing on opioids in this presentation today. This workshop is from our Let's Talk Drugs series. Some of you may be familiar with some of the other workshops that we've done in the past, covering topics ranging from cannabis, alcohol, and nicotine to discussions around difficult conversations with youth. Next month, I know we're going to be doing a national webinar on stress and anxiety and coping mechanisms. However, for this month, particularly in recognition of the upcoming International Overdose Awareness Day, we have decided to run our national webinar with a focus on opioids and discussing the complicated world of substance use, particularly with overdoses, with opioids existing sort of at the center of that problem. Now, here in Canada, you may have heard it said in the media that we find ourselves in the midst of an opioid crisis. And opioids are at the center of this ongoing overdose pandemic. And the drug supply has evolved in recent years and created new and previously unforeseen risks. Particularly understanding the role of products like fentanyl, carfentanil, heroin, and other opioids is important. And we will touch a little bit more today on some of the other substances that are currently involved in the overdose crisis, with an understanding that we will focus more on those in a future presentation looking at stimulants and sedatives. But with that in mind, this is why we've titled this presentation The Overdose Crisis as opposed to the opioid crisis. It reflects that very evolution. The illegal drug supply here in Canada has become a mixture of various products, from cocaine to heroin, methamphetamine to xylazine, fentanyl to GHB, and countless other substances that show up in the toxicology reports of hospitalizations, ER visits, and fatalities across Canada. Today, we'll explore how these drugs interact with each other, their medical uses versus their recreational, and the risks of using these products. And finally, how we as providers, as parents, as professionals who work with youth can promote health and safety for the youth, families, clients, and communities that we serve and live in here in Canada. Now, if you have any questions during the presentation, you are welcome to enter them into the chat prompt. I've also put in the link to our info at substancecanada.org if you have any general inquiries. But without further ado, we will get right into the focus of the presentation today. Now, here at Substance, our vision is to ensure that young people are able to live their lives free of problematic substance use. And the focus of this statement is really on the term problematic. Here we understand that substance use is a choice for everyone. And on the topic of opioids, there's a great deal of complexity because opioids do serve a specific and fundamental medical purpose for many people in Canada. That choice can have impact over a wide variety of factors in everyone's life. And that choice itself can be impacted by a wide variety of factors. And we'll discuss these in just a moment. Now, here we promote strategies of harm reduction with an end goal of trying to reduce the possibility of negative outcomes related to substance use. These strategies can include using substances only as prescribed by a healthcare professional, designating a sober driver, avoiding mixing drugs, and considering one's own medical history before deciding whether or not to use. Now, in order to understand the ongoing situation of opioids in Canada, we have to make sure that we understand the difference between three specific classifications of substances. The first is opioids, the second is stimulants, and the third is sedatives. We're going to be focusing on opioids today, so we need to make sure we understand its definition versus the other two. Now, before I provide a definition of opioids, I am curious to know what my audience knows. So for those of you listening, you can put this in the chat panel. What do you know about opioids? What do they do? How are they used? What have you heard about them? Feel free to put any information in the chat panel that you would like. When you hear opioids, what do you know about them? If the answer is nothing, that's okay. I'll give you a moment to think about it. Now, while you're considering your own knowledge about opioids, I do have an operational definition that I can provide. Opioids are a class of drugs. They're used to manage pain and prevent coughing. Now, they can produce feelings of euphoria, which may cause people to use them improperly. Opioids may be available from medical practitioners and by prescription, but they are also available illegally. They can be consumed as pills, injected through needles or intravenous, as well as crushed up and inhaled or absorbed through the skin with transdermal patches. And when they're used incorrectly, they pose a significant risk for addiction and other serious effects. And to put that even more simply, Opioids are a class of drugs that manage pain, they suppress coughing, they can even create feelings of calmness and euphoria. Now, the problem with this is imagine saying to someone that there is a drug that exists in this world that can take away their pain, it can calm them down, it might help them sleep, and it might take away that sort of feeling of hurt that they're experiencing. That substance sounds too good to be true. The issue is opioids can provide a great deal of those feelings, but they also come with a very significant cost and a very significant harm that we see in its responsibility for the overdose deaths and poisonings that someone mentioned in the chat panel. We're going to talk about why that actually happens. Because it seems strange to think that a medication that may be used by so many millions of people around the world can also cause so many fatalities around the world. And we'll get into that today. Now, we know this about opioids. What do we know about sedatives in general? What does a sedative do? And if you don't know, why do you think the image I chose for sedatives is a person lying down and going to sleep? What does a sedative do? They've got a pile of names too. Some people call them tranquilizers, downers, depressants. What do we know about them? Well, we know that they slow down functions in the human body. This is why they're also known as depressants. They depress the system. They can be prescribed for a wide array of issues. They can be used to reduce symptoms of anxiety. We see this with things like benzodiazepine. They may be prescribed to help someone sleep at night. These are what we know as barbiturates. Or they may keep a person unconscious during surgery, which we know as an anesthesia. They can also be used in the treatment of alcohol withdrawal. It's also worth noting that alcohol itself is a CNS depressant. More on that later. We also describe CNS depressants being used for things like seizure control and even muscle relaxants. I see someone say it puts you to sleep, it sedates you. Absolutely. When we think of sedatives, these are things that slow the body down. That's why they're used often to treat symptomology related to anxiety, people that struggle with insomnia, people that are going into surgery. One thing I often joke when I'm presenting for the colleges and universities, having a sedative is quite helpful during surgery because I don't really want to wake up halfway through and find the doctor playing a puppet show with my organs. That's really not what I want to wake up and see. So if there's something that can keep me unconscious, that can be quite medically helpful. Now, if there's something that slows you down, what does a stimulant do? Well, if a sedative slows you down, stimulant does the opposite. It increases levels of activity in the nervous system. They can increase blood pressure, they can increase heart rate, and they can increase breathing. Now, stimulants increase and they elevate feelings of alertness and energy. Some examples of stimulants may include commonly consumed substances, things like caffeine and nicotine. There's over the counter decongestants, prescription medications like Ritalin, Adderall, or Dexedrine, as well as illegal stimulants like cocaine and methamphetamine. And the reason I point out all of these examples as we go along is to try to take a little bit of the stigma out of this conversation. Sometimes when parents or professionals are speaking with youth about substances like this, we often find ourselves immediately looking at the illegal and extremely dangerous substances, the dangerous opiates, dangerous sedatives, dangerous stimulants. Any one of these classifications of substances carry risk, but they're widely used. So we have to understand that entire array and that entire spectrum of how they're used. That's why we start with this definition and remind people that they serve medical purposes. It tries to take a little bit of the stigma away and encourage a little more of the conversation. Speaking of conversation, I have a question for my audience here. In 2024, youth in grades 7 to 12 were more likely to use substances, including opioid sedatives and stimulants, from the legal, regulated, or illegal and unregulated market to get high. What do we think? I'll let the audience think about this for a moment. You can put your response in the chat panel. What do we think? This being according to the 2023-2024 Canadian Student Alcohol and Drug Use Survey. Survey takes place every couple of years, survey students all across Canada. What do we think? The illegal, the unregulated market? You see, the unregulated market does get a great deal of attention for good reason. It's very dangerous. There's a lot of harms to be considered when we don't know how these substances impact. But the reality actually is the legal market. Youth are actually more likely to report using legally regulated substances, meaning things they can get from a pharmacy or a doctor, or legally regulated substances that they get from a friend or a peer or a family member, or steal from someone to get high. Now, the most common reported over-the-counter medications that we see include things like codeine, which is an opioid, as well as Gravol and sleeping medications and dextromethorphan. The most commonly reported prescription medications used to get high were things like prescription opioids, while sedatives and stimulants were reported at lower rates, and the most common illegal drugs used to get high included hallucinogens, MDMA, cocaine, and solvents. But why do youth use substances? It's my question for the audience. Why do we think that youth would use these substances? We spend years of our lives trying to highlight risk and harm and create this sort of this system of belief that will lead people to never choose to use. We know they do. So what factors play into substance use? I see boredom, I see fun, I see peer pressure, I see coping with stress, I see trauma. Sounds like someone's been listening to me speak before. There is a little bit of a difference here. Now, in past workshops, we bring up this chart and we talk about why youth use and why youth may not. There are actually some differences we have to understand with this presentation versus, say, alcohol, cannabis, nicotine. Some of the factors that we see include curiosity. They include pleasure and fun, social factors, friends and family. But we also see the idea that many of these substances are prescribed by a healthcare provider. There's availability. One of the things that plays into why youth are more likely to use over the counter medications to get high than adults is that they're readily available. They may not be old enough to legally buy alcohol, to legally buy cannabis, to even buy vaping products or other nicotine based products. So they're looking for something to create impairment. They'll go to over the counter medications, things they can get their hands on legally. There's also a belief that legal drugs are safer than illegal drugs. And finally, there's the notion of self medication and coping. Now, if we understand all of these factors of why youth may choose to use, what might prevent them from using? What do we think? Well, there's fear, there's negative experiences, there's the judgment or stigma that may come with using, there's personal values and beliefs, and for some, there's a lack of interest. It's interesting to note if you actually look at these two lists, they're very similar to one another, even though the language is different. Curiosity and lack of interest. Youth choose to do things because they're curious about them, just like they choose not to because they don't care. Youth choose to use because they want to deal with the pleasure and the fun and the ups that come with using, but they don't want to use because they don't want to consider the legal ramifications, the risk of being grounded, charged, dealing with a criminal record, major fines, things like that. Or they don't want to deal with the health complications. There are some that use these with prescription. There are others that don't because they don't want to deal with any complications that could come with their health and well being. What becomes really important in this conversation, especially when we're talking about medications and especially when we're talking about opioid sedatives and stimulants, when we talk about alcohol, cannabis, nicotine, we talk about the importance of making informed decisions. We talk about the importance of not being judgmental. And the same thing matters here. And it especially matters here because for many people that use these substances, there may be a medical background to it. There could be someone who's using an opioid to deal with chronic pain. There could be someone who's using an opioid because they're dealing with a significant lung illness or lung infection. There's someone who may be using a stimulant to deal with symptomology of ADHD or issues with depression. They may be using a sedative to deal with anxiety related issues. It becomes very important that we don't create judgment or stigmatization when discussing these substances, because the reality is, for many people in Canada, millions of people in Canada, there may be a point in their life that they need to use these substances. So we need to take morality out of the conversation, focus on their uses, and focus on their risks and possible harms. That is different than saying if they are good or bad. That's why we don't have those conversations with youth about morality anymore. We have them about function versus risk. How do opioids work? Opioids are a class of substance. They have a long history of medical use. They're used primarily to treat pain. They can also be prescribed to support people with heavy diarrhea or severe cough. Now, we know that they release a great deal of dopamine into the brain. They create great big waves of pleasure. They also slow breathing. So some people may use them to try to relax or sleep more easily. More on that later. Now, if we want to get technical, how exactly does an opioid work? To put it very straightforward in a way that's easily understandable. One of the examples I often use when I'm doing presentations in person is to consider the brain as a collection of nodes and messengers and receiving and sending signals. One of the sort of receptors in the brain is actually called an opioid receptor. Our bodies create opioids naturally. Talk a little bit about that in a moment. But what happens is when we receive signals from the body, for example, if I'm walking around my room, if I'm moving here at my desk and I hit my elbow or I hit my kneecap on my table, does my kneecap or elbow tell me I'm in pain, or does something else tell me that I'm in pain? What do we think? Does my knee tell me that I hurt myself? My brain does. The signal travels from my knee up to my brain very quickly. My brain interprets that signal as inflammation, saying that's pain. Tells my knee to swell up, tells me to get away from the table, tells me to get upset, cry, yell, however I'm going to respond to that pain. That's an opioid receptor's job. It responds to that incoming signal. The way that an opioid works when we consume them is it puts a blanket over top of that receptor. So that what happens when a signal comes up, identifying pain, the need to cough, irritation in the throat, that receptor is blocked. So it cannot receive the signal. So it does not take away our pain. It simply makes our brain forget how pain actually works. Okay. In small doses, in carefully prescribed doses, these can be medically beneficial. If we have someone dealing with significant pain from major invasive surgery, car collision, some form of a chronic serious injury, pain associated with neurological disorders, with cancers, there is a medical use there. Opioid receptors themselves even block off the signal to cough in response to irritation in the throat and the lungs. So this could be helpful for someone dealing with severe lung infections. This is what codeine is meant to be used for in cough suppressants. We even see that there's opioids like loperamide, which we find in Imodium, because those opioid receptors also tell the gut to create fluid. So if a person has diarrhea, opioids can actually stop that from happening. All of these things are medical potentials and applications. Now, again, the way they work, they bind to the receptors in the brain, they bind to the receptors in the spinal cord, and they bind to the receptors in the intestines. That's what creates all of those responses. Now, the side effects of opioids can range from mild to life threatening. We'll start with the mild ones. We have drowsiness, we have headache. Of course, drowsiness would happen if the person's breathing is slowing down, as we mentioned a moment ago. There's constipation, which makes sense. If the gut is no longer creating fluid, there's the possibility of constipation. Overuse can also cause things like vomiting or confusion. Now, it's also worth noting that opioid use can also cause sexual impotence in men, as well as irregular menstruation in women. For pregnant women, for expecting mothers, opioid use during pregnancy, especially if used chronically and over time, can actually cause neonatal opioid withdrawal syndrome, whereby a baby is born essentially in withdrawal because they're no longer absorbing opioids from the mother. This can be very dangerous, even fatal for a child in the first 24 hours. So if there's anyone who's pregnant or planning to become pregnant, if they're using opioids, they need to speak with their healthcare provider about this and see what other options may be available to them. Now, many of us use these drugs for medical purposes. We use them with prescription. But I always like to ask this question: would you use the same degree of substance that would knock out an elephant? And to ask this question, we had our partners at Savoir Media create a lovely 2-minute PSA about opioids to ask and answer this very question.
Substances make us think of products that we can obtain legally or not, and take recreationally or not. But whether it's cannabis, MDMA, or creme de menthe, they all have one thing in common: they're intended for human consumption. So, what if someone told you that the substance you're about to take was designed to put an elephant to sleep? You wouldn't touch it, right?
Mind-blowing! Everything you need to know about substances.
Would you take the same sedative as an elephant? Carfentanil is one of the most powerful sedatives on the illegal market. It's a synthetic opioid that was intended to be used as a tranquilizer for large animals. It's 100 times stronger than fentanyl and 10,000 times stronger than morphine. It will definitely put a walrus to sleep faster than a few shots of creme de menthe. Since it's so powerful, it's a lot easier to traffic because a tiny amount can be used to create countless doses. Just 20 micrograms of carfentanil can kill a healthy person. To give you an idea, 1 microgram is smaller than a grain of salt. Carfentanil dissolves in fat, so it spreads very quickly through the body. Because, just like a walrus who loves to party, our cell membranes are made up of fat. The drug causes respiratory distress that can be fatal in the case of an overdose. Drug traffickers often cut carfentanil with other illegally obtained medical sedatives to maximize their profits. When sedatives are taken with a prescription, they can be safe, but outside of these parameters, they can be extremely dangerous. Unless you're a really stressed out elephant, you're better off staying far away from sedatives on the illegal market.
I would like to kind of lead off with that PSA on opioids, particularly on carfentanil. Carfentanil is the most potent opioid that we currently see, particularly in the illicit market. Now, the vast majority of opioid overdoses we currently see are fentanyl. But if we actually look at overdose numbers in 2026 and 2025, we have seen an increase in the amount of overdoses that have tested positive for carfentanil. For example, I was actually just looking through the research in Alberta on their provincial surveillance and found that their carfentanil numbers were the second or third highest numbers that were actually found in polysubstance overdoses. So when we ask this question, would you take the same substance that would knock out an elephant? The simple answer is no, but the unfortunate reality of the drug market, particularly the illicit drug market and the unregulated drug market, is that substances like carfentanil, like fentanyl, methamphetamine, cocaine, heroin, benzodiazepines, medetomidine, bromazole, etc., have found their way into this supply, and they've created a great deal of risk. But let's step back for just a moment. In 2021, the government of Canada estimated that what percentage of Canadians experience chronic pain? Is it 5%, 10%, 20%, or 25%? What do we think? I'll give you a moment to think of this. See, 20%. Any other votes from the audience? 10%. Think about this, 20%. So we're in the 1 in 10, 1 in 5 range. Let's see. Survey says the answer is 20%, or approximately 1 in 5. So this would equate to about 7.6 million people in 2021. And in 2021, Health Canada actually established what they called the Government of Canada's Canadian Pain Task Force, which, by the way, is maybe the greatest name for a research group I've ever heard. If I got contacted by someone that told me they were from the Pain Task Force, I feel like I would probably answer any question that they had, personally. But the aim was to improve the approach towards prevention and management of pain. What the research found was that 1 in 5 Canadians experience chronic pain, and 1 in 5 youth report chronic pain, while this number ballooned to about 1 in 3 among seniors. Now, not only is chronic pain common, but there is a significant strain on the healthcare system to treat it. The average wait time for pain treatment in Canada is 6 months. In fact, 1 in 5 treatment facilities across the country reported wait lists of 12 to 18 months or longer. So with this significant period of wait, with this significant amount of time and this strain on the system, there was a need for something that people could use in the interim. So here's what we found. In 2020, 1 in 8 Canadians were prescribed opioids. Prescribed opioids for chronic pain, after surgeries, motor vehicle accidents, and for various health complications. Imagine going to a healthcare provider today, telling them maybe you had a traumatic injury from a car accident a few months ago, and you're still dealing with chronic pain in your back or in your legs. And imagine your provider going, "Oh, that sucks to hear, man. I'm sorry. Come back in spring of 2028 and I'll see what I can do for you." You're not going to thank the healthcare provider or the service provider for not doing anything for you. You're going to look for something for treatment. You're going to look for something that you can do to help, whatever that would be. Some form of physical therapy, some form of physio, some form of support. But in many cases, what people turn to were opioids to manage that pain. Now, opioids are found in various different places. We have our naturally occurring opioids. I mentioned this a little while ago, that opioids are actually found in the human body. So we actually see opioids in what we call endorphins. If you've ever heard of endorphins from people, these are naturally occurring opioids. And a perfect example of endorphins, if you're ever trying to talk about them with a youth, or talk to them about a runner. someone who's been running for a long period of time, distance runners. They often talk about this thing called a runner's high. Their body is burning. They can barely breathe. They're exhausted. They're winded. They're breathing heavily. And all of a sudden they hit this moment where their pain starts to subside and their breathing slows down and they almost feel at peace. They feel at rest. They talk about a runner's high. That runner's high is the flow of endorphins, the flow of opioids through their brain and through their receptors. That is what they're feeling. That is a natural response. That's why our bodies have opioid receptors. It is to try to block pain. It is to try to calm us down. More on that in a moment. We also see them processed from the unripe seed pods of the opium poppy. Examples of this include things like morphine and codeine. Next up, we have our semi-synthetic opioids. These are made by modifying a natural opioid. Examples of these include heroin, oxycodone, hydrocodone, buprenorphine, or hydromorphone. Now, those might sound like big words that you might not remember, but I'll give you some examples. Oxycodone is also known as OxyContin, more recently Oxy-Neo, after OxyContin was no longer allowed to be sold in Canada, as well as Percocet. You have Vicodin, which is your hydrocodone. You have Sublocade, which is your buprenorphine. And hydromorphone is also known as Dilaudid. So if you're talking with any clients about any of these, you're talking about opioids. Now, it's worth noting that Sublocade and Suboxone are both used to treat opioid use disorders. Suboxone is a mix of buprenorphine in combination with naloxone. So a lot of different names to consider here. Now, the third type we hear are synthetic opioids. These are manufactured chemicals created in laboratories. They're not natural. They're literally just created synthetically. Examples include fentanyl, carfentanil, meperidine, also known as Demerol, as well as methadone. And the reason I like to list this is sometimes when I talk about opioids, especially with families, especially with communities, they say, well, I don't know any opioids. But as soon as I start listing these names, they become more familiar. I get clients that talk to me about hearing about Dilaudid, hearing about Oxy-Neo, or 15 years ago, OxyContin. They talk to me about being familiar with morphine in surgeries. The point is, this is a far more normalized substance than we realize. Is it legal to share an opioid with someone who has the same or similar health issue as you? I mentioned we can use them to manage pain. Let's say I was prescribed a low dose opioid because I broke my ankle. And while I'm out for a walk with a friend of mine, they break their ankle. But can I give them some of my opioid because they have the same health problem as me? Am I allowed to do that? What do we think? See a vote for nope. Anybody else? What do you think? Treating the same thing. The answer is you do want to challenge the statement. It becomes very important that you protect yourself. The legal ramifications for actually sharing an opioid with somebody else, I'm going to go back here for a moment. The legal ramifications for sharing an opioid with someone else is that they can take up to even like 18 months in prison. And the reason that there's such a risk is because what may work for me may have a much stronger effect on someone else. And furthermore, I can't give my opioids away. So it becomes very important that I have to protect myself. And how do we do this? We recommend that you take opioids as prescribed for as long as needed. Now, opioid use can cause impairment and affect the way that you think and understand the world around you. So you should only use them in a safe space around people that you trust. If you are coming up on the end of a prescription, you need to speak with your healthcare provider about other strategies and things that you can do as you work towards managing pain. They may extend your prescription. They may not wish to. They may be concerned about a potential for dependency, and they may look at other treatment options. Now, opioids can interact very dangerously with alcohol and other substances. And we talked about this in previous workshops about how alcohol really doesn't play well with other substances. It is not recommended to use alcohol in conjunction with any other substance, especially opioids. If you are taking any other medication, let your healthcare provider know before you start to use so you can be made aware of any potential risks with mixing, especially if you're using any illicit substances. Now, how do we protect others? You don't share your opioids with anyone else. You keep them stored in a safe place, out of reach of children and out of reach of pets. Now, I'll tell you a little story. I had a dog. Here's a picture of him. I like putting him up on the screen to give you a little bit of an illustration here. He's a sweet dog. He's a cuddly dog. He was not the brightest of dogs, but he was very sweet. He would eat anything. He was a hound. He would eat absolutely anything. If I left out food, he would eat it. If I was making food, he'd try to sneak in the kitchen and eat it. If I was someone that used substances, which I'm not, but if I were, there would be nothing to stop him from going in and trying to eat them. And I'm sure many people listening can speak to this as well. Perhaps they themselves have a pet, perhaps they know a relative that has a pet. Pets do not understand what is and what is not medication. And a pet cannot tell you that they ate your drugs. The dog's not going to come into the room and say to me, like, hey, Steve, I ate that bottle of pills that was sitting on the table. Or you made some hot brownies, I ate all of those. No, the dog is going to react in unpredictable ways, similar to a small child. They could get sick, they could get very emotional, they could get violent, they could get aggressive, they could get nervous, they could get anxious, and in some significant cases, they may require emergency medical attention. And I will say on a side note, if you are someone that uses substances or you know someone who uses substances and they have a dog, and the dog ever comes in the room and tells them that they ate their drugs, I strongly recommend that you or they also take a break from using substances because, well, your dog can't talk. Just so we know. Don't want to spoil any dreams that we have. The dog can't talk. So take as prescribed. Don't share with anyone else. Now, how do we protect our community? Well, we keep opioids stored in a safe place to prevent theft, and we return unused medications to a pharmacy. Next month, we'll be doing an activation event in partnership with Rexall here across Canada about safe return and drug drop off. It is very important to return unused opioids, unused sedatives, unused stimulants to a pharmacy, especially if they're expiring, where they can be safely disposed of. Not dumped down the drain, where they can poison or corrupt water tables, not left in the cupboard where they could potentially be stolen or accidentally used, but returned to a pharmacy where they can be safely and effectively disposed of and destroyed so that they don't wind up finding their way into the unregulated market or accidentally into the wrong hands. Now, I've spent a great deal of time talking about medical applications and medical uses and ways to protect ourselves medically. But why do we have to have a conversation about protecting ourselves medically if this substance carries so much medical application and benefit? What makes it so risky? The answer is there's two things. First is the potential for misuse. Using opioids can actually cause the brain to produce endorphins that create that feeling of calmness and relaxation, as well as the production of dopamine. Dopamine is the chemical in the brain that creates pleasure. It creates motivation. It detects feeling and mood and focus. When we do things that we enjoy, our brain naturally releases dopamine. As you're learning new information today, your brain is releasing dopamine. Say, hey, I like this. I'm focusing. Let's keep learning. Opioids cause a synthetic release of dopamine. In fact, Yale School of Medicine in 2024 estimated that substances like nicotine and opioids can actually release levels up to 10 times of dopamine of what the brain would normally release. This creates that overwhelming feeling of euphoria. But when a brain receives this feeling, one of the more common issues is that it wants it again. And so it keeps going back. It goes back to the opioid. It goes back to the nicotine. It goes back to the cocaine to try to get that feeling of pleasure. And this repeated use may create a feeling of a need to get more. And as they use more, the effects become less strong. So they start to use even more to feel the same effects. Here we have the development of a dependent or problematic use, formerly known as an addiction. And about 10% of Canadians who use opioids will become addicted to using it. But addiction itself isn't fatal. So what is? It's respiratory failure. I mentioned earlier that opioids are responsible for responding to pain, responding to irritation. They're also responsible for creating fluid inside the gut. One thing that opioid receptors also do in the brain are that they tell the lungs how to breathe. We don't sit and consciously think about our breathing all day. Opioid receptors communicate that signal back and forth to our lungs to make us breathe. The reason that opioids slow your breathing and calm you down are that they cause the brain to partially forget how to breathe. Our breathing becomes slow. It becomes uneven. In small doses, this might make us relax. This might even make us fall asleep. But if we consume too many, this can actually make a person forget how to breathe for a period of 10, 12 hours, 8 hours, 10 hours. If a person stops breathing for 12 hours, what is going to happen? Not even 12 hours. If they stop breathing for 3 to 5 minutes, they're at risk of brain damage. If we get to 20 minutes, 30 minutes, an hour, 2 hours, 4 hours, and that person's still not breathing, what's going to happen? In the past, when we talked about substance awareness and education, we talked about the importance of not fear-mongering. This is not fear-mongering. It is a statement of reality. If a person does not breathe for 12 hours, exactly, they will die. There's no nice way to put that. There is no sugarcoating way to put that. That is the most honest take I can give you. This is the risk of opioids. It is not that they make your heart stop. It is not that they, um, create like these feelings of overwhelming euphoria, and the euphoria is fatal. It's not that contributes to it, because as we keep using and we keep increasing our dosage and looking for stronger opioids like fentanyl, like heroin, like carfentanil, we increase our risk of shutting down too many opioids, not breathing, and unfortunately passing away. Now, what if the person survives? The danger of death from an opioid overdose cannot be overstated. However, surviving the overdose does not guarantee that things are going to go back to normal. Cutting off oxygen to the brain for any period of time, for any reason, can result in brain damage. For those who've experienced a brain injury, they may take time to even acknowledge that they've changed. They may notice things like weakness of limbs, a loss of motor control. They may have issues with balance or coordination. They may struggle with vision, speech. They may struggle with memory loss. They may even feel like a different person altogether, as brain damage can even change facets of a personality. These symptoms can be troubling for the individual and those around them, and they may have a hard time recognizing the person that they once knew. When an overdose results in a brain injury, the harms and outcomes are far more significant. Overdoses resulting in a co-diagnosed brain injury are more likely to result in longer hospital stays, intensive care unit visits, and dying in the hospitals. In fact, the rate of death at the hospital with a brain injury is 70% versus 3% without one. So not only can an opioid overdose cause an injury, but people with a brain injury are also more likely to report developing issues with substance use, including opioid. So someone that used to the point that they overdosed, the point that they've damaged their brain, 1 in 5 people that have acquired brain injuries, for example, through overdose, will actually develop a substance use disorder. You would think that this moment of harm, this moment of significant harm, would be a deterrent for them. The unfortunate reality for many is that they may turn then to using substances. So just to say that they survived is a positive. It's good that they did, but there is still so much work and so much support that the individual needs. The opioid crisis in Canada has contributed to more than how many fatalities since 2016? Is it 10,000, 20, 35, or 55,000? What do we think? 55? Any other votes? The answer here is 55,000 people. Since 2016, over 55,000 people have died of suspected overdose, and an additional 51,000 have been hospitalized due to overdose. It is worth noting that 2 milligrams of pure fentanyl is enough to kill the average adult. Now, in hospital settings, fentanyl is given out in the microgram, in the 1,000th of a gram. Research from the DEA in the United States actually found south of the border that up to 40% of illegal drugs seized that contained fentanyl contained 2 to 5 milligrams, which was up to 2.5 times the lethal point of injection of opioids. Fentanyl is far more potent than its predecessors. It's 20 to 40 times more potent than heroin and 100 times stronger than morphine. And again, as we mentioned earlier in the video, another synthetic opioid, carfentanil, is 10,000 times stronger than morphine. It is not intended for human use. Fentanyl was intended to be used medically to treat severe pain for patients dealing with advanced cancer, significant physical injury, or undergoing traumatic medical treatments or surgery. However, as it is a powerful opioid, it has the risk for both misuse as well as overdose. Now, how does fentanyl enter the unregulated drug supply? How does it wind up going from a hospital into a party? Where is the gap here? What happens? Well, many people, especially from unregulated sources, may receive fentanyl without even knowing that it's in their other substances, with the opioid they're taking, the stimulant, or any other illicit product, particularly in the illegal market. Now, illegal fentanyl enters the market in 3 ways. First is that it may be imported from other countries. It may be produced illegally or stolen from medical sources and then repurposed. Or, I'm sorry, the second and third. But illicit drug producers and suppliers will often mix fentanyl or carfentanil into pills and injections that they produce because since you only need a very small amount, it is essentially cheap to work with and provides a quick return for them on their investment. They see it as a way to make money. Believe it or not, your dealer might not have your best interest in mind. This is why it's very important that we don't look at recreational opioid use the same way that we do with medical opioid use. There is a regulation there. There are strict steps, etc. There are strict guidelines there. A dealer does not have any of those. They don't owe it to anyone to even tell them what's in their substances. And in many cases, dealers may not even know what they're getting from a supplier or a producer. These drugs can be mixed together with coke, with benzos, with meth, and labeled incorrectly as prescription opioids. I mentioned a moment ago that there are many people that may take an opioid without even knowing that they used. Does anyone know what percentage of opioid overdoses are accidental, according to surveillance? Now, when I say an accidental overdose could be if someone consumes more of the substance than they intended, for example, taking an unregulated product, not knowing how strong it is. It could be they consume the product without knowing they're doing so, for example, taking a substance that has fentanyl or another opioid without knowing it's there, or someone mixes two or more drugs together without knowing their effects. What do we think? What percentage of opioid overdoses are accidental? 57, 57, 96%. The overwhelming, near total majority do not even know this has happened. It is sudden. An opioid overdose can knock a person unconscious in 2 minutes. They don't even know what happened. All they know is they felt good and they relaxed, and all of a sudden, for all they know, they might not wake up. So, what does it look like? What does an opioid overdose look like? What are the signs that we need to look for? We need parents to understand this. We need providers to understand this. Anyone who works with someone who may be using an opioid. It is important to know that an overdose can occur within 2 minutes of use. Opioids bind to the receptors in the brain that regulate breathing, so too many can actually shut down the respiratory system. So signs of an overdose include discolored lips or nails. You may notice that fingertips and lips may start to turn purple in lighter skinned people. In darker skinned people, they may turn green. That is just because of pigmentation in the skin. I just point that out if you're working with someone who, say, has lighter skin versus darker skin. The color may be slightly different. Could be green for darker skin, purple for lighter skin. You may find the skin itself becomes clammy. It becomes pale. You may find the individual is confused, they're dizzy, they're having a hard time staying awake, walking. You may also notice that they fall asleep for brief periods of time and then wake back up. I often joke when I'm presenting in person that this is sort of that moment that, maybe the audience is doing this. They're starting to doze, they wake back up. Starting to doze, they wake back up. It's called being on the nod. Think about staying up late and trying to watch a movie or watch a sporting event in the middle of the night. You really want to watch it. And all of a sudden you realize you were asleep for 10 minutes. Then you missed 5 minutes. Then you missed a whole commercial break. Then you missed a whole period. Then you missed part of the movie. It's being on the nod. You're coming in and out of consciousness. You may also notice that while that person is unconscious, they may start to snore, they may start to choke or start to gurgle, particularly if they haven't before. But even if they do have, say, pre-existing sleep apnea, you may hear this more pronounced. It is worth noting that the sound of snoring is the sound of a person not breathing. It is a sound of air simply moving by those muscles in the back of the throat. At this point, they are not breathing. And you may notice they're unresponsive. You also may notice that their breathing has become irregular, as I mentioned, it stopped, or their heart rate has slowed or stopped altogether. Of course, in the case of the bottom two, these are immediate life-threatening complications. So what do we do? What is the name of the product available across Canada that can temporarily reverse the effects of an opioid overdose? Is it adrenaline? Is it naloxone? Is it epinephrine? Or is it none of the above? I see vote for naloxone. I see vote for naloxone. The awareness of naloxone going up is a very, very important thing in this situation, and you are all correct. Naloxone's role is to temporarily reverse an opioid overdose. It is available as a nasal spray or an injectable. And to respond to the overwhelming risk of opioids overdoses, there is naloxone. We also know it as Narcan here in Canada. What it does is it binds to those same receptors in the brain that an opioid normally would, so that the opioid can't do that. The way I often show it when I'm in person is if I have a chair or I have a pen, I put a cover on it to show an opioid. What Narcan does essentially pulls that cover off and allows the opioid to send and receive signals again. So this can make the person start breathing. This can reverse the effects temporarily. Now, it will usually work within 2 to 5 minutes, but you may have to administer more than one dosage. This is especially the case if a person has either used heavy amounts of strong opioids or they've used other drugs like stimulants or certainly sedatives. Because the problem with a sedative is it may slow the body down to the point that a person stops breathing or barely breathes, but Narcan will not reverse it. Narcan doesn't have any impact on alcohol as a sedative. It doesn't have any impact on xylazine or medetomidine as a sedative because that's not what it's designed to do. It's designed to reverse the opioid itself. It gives them a fighting chance, but if they have other drugs in their system, which we'll talk about in a future workshop, there is a significantly increased risk of fatality because Narcan may not wake them up. This is where you hear testimonials of people being Narcaned 10 times, 15 times, 20 times. I've dealt with law enforcement that have had to Narcan people 18 to 25 times on a single occasion and could still barely wake them up. In these situations, there's a strong possibility there's something else mixed in. It's also worth noting that even if the opioid does work, the relief is only temporary. Narcan only works for about a period of 20 to 90 minutes, but the effects of an opioid can be 8 to 12 hours. So you may Narcan someone, you may administer Narcan, they may wake up, have a full conversation with you, and then fall back asleep and stop breathing an hour or two later. If you ever have to administer Narcan, you have to consider the following. You need to know what an overdose looks like. Is the person breathing? Are they snoring? What color is their skin? Have they, recently taken a substance? Are they responsive when you try to wake them up? Stay and help. If there's someone there, call EMS while administering Narcan if you have it. You may even be asked to do things like chest compressions. Narcan packs even have a one-way breathing mask that you can actually put over someone if they've overdosed that you can administer mouth-to-mouth resuscitation if the person is comfortable doing that without having to worry about taking something back through the mask. It's a one-way mask. Now, I do like to point out, if there is ever someone that is given Narcan and wakes up, it is very important to understand that they may not wake up grateful that you've reversed an overdose because you have to consider their situation. They took a substance that calmed them down. It took away pain. It took away anxiety. It relieved them. And then they fell asleep. That's what they know. That they don't know in many cases that they overdosed. They don't know that they almost died. All they know is they went from any given situation whereby they maybe felt more comfortable to all of a sudden being on their back feeling pain because the opioid has been reversed in their body with a total stranger standing or lying or kneeling right over top of them trying to support them. For many people, this can be very overwhelming. It can create anger, it can create rage, it can create violence or aggression when they wake up. So if you are Narcanning someone, make sure you're very loud about it, you're very audible about it, that as they're coming to, you're letting them know what happened and you're giving them space because they may become violent. Just so you know. Now, someone calls 911 to report an overdose. The person who OD'd will be charged for possession of a controlled substance. Accept this or challenge it? It's the last question I have for us today. What do we think? Challenge? Anybody else? Challenge accept? Challenge? You do want to challenge this one. It's good that the audience is aware of this. The reason you want to challenge this is because in 2017, in recognition of what's been going on with the ongoing overdose crisis, the government of Canada signed into effect the Good Samaritan Drug Overdose Act. This is a measure of harm reduction and a means to promote prevention and treatment. Anyone who calls emergency services in response to an overdose is legally protected from charges against possession or breach of conditions related to release involving possession, things like release, probation, or parole. In other words, if a person calls for help or someone else calls for help, and the individual has a small amount of a substance on them or have taken a legal or illicit substance, they won't be charged criminally for doing so because the risk to their life supersedes the need to charge them. Now, the act itself is not a cure-all, and I'd like to point this out. It's very important. This is not a cure-all or get out of jail free against any other crimes, period. There are certain things that the person may still be charged for. These include outstanding warrants, production or trafficking of drugs, or other crimes not included above. 2 examples. If a teen is at a party, they or someone else they know overconsumes on a substance, they become non-responsive. EMS is called, EMS arrives. They may ask if you know what the person took because they're trying to figure out what they may need to do to treat them. They'll say, thank you for letting us know. Take it from there. No charges filed. Now, if EMS shows up and they find a different crime being committed, if they show up to treat an overdose, a non-responsive, and they see within plain view a meth lab, if they see an assault going on, if there's some other illegal activity going on, there can be charges filed for those, but not for the response to the overdose itself. So in short, if you see or experience an overdose, it is important to call for help. Not just because there's legal protection, but more importantly, it can save a life. Before we wrap up, the very last thing we want to make sure we cover is the spectrum of use and signs of misuse. So, when we look at the spectrum of use, substance use exists on a multitude of spectrums. And I do see a question in the chat. I'll make sure I get to it to the end as well. When we look at substance use, the beginning is non-use. Many of us who are listening today don't use substances. And you might say, well, that's a presumption, but I mean, it's more likely based on statistics that most people here don't use certain substances. There may be people here that smoke, there may be people here that drink. Absolutely, there may be people here that use. I'm not here to judge about that, just pointing out what we know. The majority of people don't use. And one thing about abstinence-only approaches, I will say, is that abstinence is the most effective way to avoid harm of a substance. However, we understand that people have choice. This is why abstinence-only practices tend not to work, because they ignore the aspect of choice. There are people that will choose to use knowing that there are harms. There's beneficial use. Prescribed and legal use of substances can actually have positive health, social, spiritual effects. There are hundreds of thousands of people every year in Canada that use prescription opioids, sedatives, stimulants. They use them with medical license, with medical support. They use them with prescription. They use them in support of a healthcare provider. They use them in safe spaces. They use them with people that they trust that can have positive health outcomes. There is still low risk use. These uses may even have a minimal impact. This is why when we're given a prescription, we hear about the potential side effects, the potential risks of harm. Now, low risk use is when the use has a minimal impact on a person's life. But where we see more problematic use is where more harms start to emerge. And I'll show those in a moment. And finally, where we see disordered use, this is whereby a person is experiencing a treatable and medical condition that involves compulsive use despite negative effects. It's also worth noting that a person can move back and forth between stages of use over time. You may have clients, you may have friends, you may have youth, you may have your own children, you may have siblings, you may have neighbors that are struggling with disordered use. They may quit. You may have people that struggle with disordered use, they scale back and go back into it. You may have people that never use. You may have people that just use casually once in a blue moon. No matter where they are on this spectrum, it's never too late. And it's never too early to learn more about these sorts of things. And it's not about us trying to judge them based on where they are on the spectrum. It's understanding for their sake what harm they may be facing as they move further to the right of the spectrum and why it is that we care and we're trying to show concern as we try to help them look at ways that they can maybe move a little bit more to the left. But ultimately, that choice has to be theirs. And one of the best ways we can insulate that is by showing our compassion, our empathy, and our support, as opposed to simply labeling and judging them for where they are. Now, signs of harmful use. What does the right side of the spectrum look like? These are things like tolerance, whereby a person has to keep using a substance to get the same effects. Cravings or withdrawal when they feel unwell when they're unable to use. Declining health conditions, even if that health condition may seemingly have nothing to do with the substance that they use. I often like to use alcohol as an example of this. Alcohol is implicated in over 200 short and long-term risks to the human body. And as I mentioned, opioids themselves can have life-threatening risks. So we understand that there are the potentials for overdose here, the potentials for hospitalization. These are signs of harmful or problematic use. If a person is using, especially knowingly, to the point of risk, this is a sign of harmful use. But overdoses can also be accidental. That doesn't take away from the fact that there is harm experienced. Behavioral signs include isolation, avoidance, or lying. We talk about people that use substances to socialize earlier, but it's also worth noting that a sign of dependency is when we start spending less time with the people that matter to us in favor of substance use. That is isolation. That is a sign of dependency. Falling into debt, Breaking rules, declining performance at school or at work can all be signs of harmful use. And finally, where we see psychological signs, these include difficulties with learning. These include new or worsening symptoms of stress, anxiety, or depression. It is worth noting that the long-term use of opioids is associated with increased issues with both anxiety and depression, as we talk about in another one of our workshops. There is an increased risk of intrusive or unfamiliar thoughts, particularly from using substances over a long period of time, as well as hallucinations, delusions, and finally, with all of that in mind, what are the strategies that we want to make sure we take away from today? What are the things we want to make sure we speak with our kids about, the conversations we want to make sure? The first is to use opioids as prescribed and directed. If you know someone that's using an opioid, where are they getting it from? If they're getting it illegally or from an illicit provider, have they had it tested? There are testing strips available at many different health units, service providers, housing providers, safe consumption sites, depending on where you are in the country. Certain Indigenous providers in many communities may have them on hand. Health units may have them on hand at local hospitals or health centers. Use substances only from trusted sources. If you don't know where a substance is coming from, you don't know what's going to happen if you take it. So it becomes very important to trust the source you're getting it from. This is why we recommend being in communication with a healthcare provider. Pick up a Narcan kit from a pharmacy. There are people that I've heard say in presentations to me, I don't want to have Narcan in my house because I don't want to make it seem like I support someone using opioids. I understand where the concern is coming from. They care enough they don't want this person to hurt. But what they don't realize is they're taking away security. Saying I don't want Narcan in my first aid kit is like saying I don't want Band-Aids in my first aid kit because I don't support people getting hurt. Getting hurt happens. Unfortunately, opioid overdose can happen. And in many, many cases, it happens accidentally. It's better to have one of these and not need it than need it and not have it. Avoid mixing opioids with alcohol, medications, and other drugs. Designate a sober driver. Opioids can cause sedation. They can cause issues with confusion, dizziness, weakness, not certain situations you want to be driving in. And finally, avoid substance use if you're pregnant, have a history of psychological or substance use disorders, and if someone is using an opioid, they should only use in a safe space with someone that they trust nearby. Using opioids alone can be life-threatening because if a person stops breathing and there's no one around to call for help, there is the immediate risk of fatality. Seek medical attention, even if you administer naloxone. I'd like to thank all of you for joining us today. It's been a busy last hour, and I do certainly hope that you take some time to follow the QR code here to fill in our survey. If you have any questions, I am certainly happy to stick around after the call or after the presentation wraps up to take any questions that you may have. Otherwise, I would like to thank you all so much for joining us today, and we certainly hope to see you at our upcoming webinars in the coming months. Please take a moment to fill out the survey. You'll see there's a link provided in the chat panel. Otherwise, we hope that you enjoy your day. And as I mentioned, I will stay on the call if there are any questions. Thank you all. Take care.